wants more, it wants more. So it maximally extracts all the oxygen. So when you draw your specimen, right, your mixed venous oxygen is low, right? It's low. And when you don't get enough oxygen to the tissue, what happens?
It's going to die.
Okay, good. So you go from aerobic metabolism to anaerobic metabolism, and then what do you produce? Lactic acid. So that's why when you see a lactic acid, you should say to yourself, wait a minute, right? Wait a minute, we're not doing a very good job here. Well, trend lactates, the lactate's going from 7 to 5 to 4, you know you're headed in the right direction. The lactate's going from 4 to 5 to 7, right? You're not headed in the right direction. You got to do something else. So that's it. It's not rocket science. And this is what we do each and every day in the ICU when you look at this, right? Okay. So now you all, it's perfect, right? So, well, here's the vital signs. What interventions would you do to decrease oxygen consumption? So I got somebody that's really consuming a lot of oxygen. Is there anything that I can do to decrease oxygen consumption to make it better for the patient?
If patient is shivering, just lower.
Good.
Yeah, like
temperature. Very good. What else? Intubate and sedate. Absolutely. And sometimes chemically paralyzed, right?
Yeah.
Take away the work of breathing, right? So absolutely right. Very good. So antipyretics, intubate, sedate, sometimes paralysis. These things would decrease oxygen consumption. What interventions would increase oxygen delivery?
Give oxygen.
Okay, so we know this, all right? So we said increase inspired concentration of oxygen, increase cardiac output, right? And give blood, right? Because these are only the three things that if you have a patient who has a low mixed venous oxygen saturation, you say, I need to increase oxygen delivery. There's only three ways to do that. They're all not equal, right? But there's three ways to do that. One is increasing inspired concentration of oxygen, automatically, 100%, right? Then we say, okay, what about cardiac output? And cardiac output can be increased by a multitude of ways. A, give volume. B, give blood. C, use a balloon pump, right? So there's different things depending on what type of shock you have, whether it's hypovolemic shock, whether it's cardiogenic shock, whether it's septic shock. All these things are different in terms of what kind of infection you're dealing with, right? But that's how you're going to increase cardiac output. And cardiac output's the biggest because there's a lot of different variables in how you can do that. The others are straightforward. Increase inspired concentration of oxygen. The others, give blood. If the hemoglobin's less than 7, right, we're going to give blood, right? Because red cells is what carries the oxygen, right?
Yeah.
So it's transfusion, cardiac output, inspired concentration of oxygen. That's it, right? And that's what we do every day. So, you start pulling this together. So here it is. Fluids, blood transfusion, supplemental oxygen, and vasoactive agents. Now what we're beginning to find out is that we're not giving so much fluids as what we used to, right? And there's some other data that's coming out in terms of now you're seeing we're using vitamin C, the vitamin C protocol, where we're giving vitamin C, steroids, and thiamine, to these patients. And we're finding by doing that, right, that they respond better, then ultimately they'll end up requiring so much fluid because you pound with a lot of fluid. If you think about what we do to patients, it's really strange. It's simple. We do it every day, right? What do we do? We put a tube in every body orifice. We put a tube in every body orifice. And then we pour in a bunch of fluid. And the next day, we want all the fluid out and all the tubes out. But that's it. That's what we do, right? So pouring in an excess amount of fluid, what we've learned is that it doesn't do the patient any favors, right? So we got to be careful in terms of doing that. So now what we're finding is that once we're meeting certain endpoints of resuscitation, that we're going now to, a vasopressor to tighten them up a little bit. We're getting this, we're getting that, right? And we're not going to get 12, 15, 16 liters of fluid, right? Because then they get blown up like the Stay Puft Marshmallow Man, and then you want it all back, and it takes time to get that back, and it's fraught with other problems and other issues. So which fluid would you administer in a patient who is in shock? So, well, it depends on what kind of shock they're in. If they're in hypovolemic and they're in hemorrhagic hypovolemic shock, you're going to give them blood. If they're in non-hemorrhagic shock, you're going to give them a crystalloid, right? And I'm not going to sit here and debate about colloids. All I'm going to say is whatever is needed, you should give to be able to meet endpoints of resuscitation, right? So now we've intubated them, they're sedated, they got gas in the tissue, their blood pressure is what it is, their heart rate's 150. How much fluid is needed? right? Well, the answer is
It depends.
it depends, right? And the point here being is that there has to be endpoints of resuscitation that you're looking at, right? So I'm looking at the arterial blood gas. I'm looking at the acidosis. I'm looking at the lactic acidemia. I'm looking at other indicators of end-organ infusion. I'm looking at urine output. There's multiple things I'm looking at. And once I get to a point, I say, okay, enough is enough. And sometimes we need more information. So we put in central venous catheters. We don't really put swans in anymore. But, we'll put in a central venous catheter and we'll follow central venous pressure, on these patients. Even though central venous pressure is not a great way anymore of really determining intravascular volume, it's a number, that is somewhat useful in terms of us being able to resuscitate patients. Okay. Another important thing is that, flu boluses we talked a little bit about. The goal here obviously is to correct hypotension first, then perfusion, and monitor oxygenation. And this is another one which I think is very, very important. And again, that I think we learned with the swung venous catheter, is that you give enough, volume, right? But once you start seeing that you're going up on the FiO2 or you're going up on the PEEP, you got to stop. So the common question is that people come and say, should I give more fluid? And I'll say, well, what FiO2 are they on? Well, they're on 40%. What's the measured PaO2? It's 250. I go, the lungs are dry, give more fluid. On the other hand, you all come over and say, I'm giving fluid, but the O2 sat's dropping, peak pressures are going up on the ventilator, and I would say, no more fluid, right? Then I have to go to another alternative, which is tighten them up. Because they get increased lung water.
Yeah, the lung cannot take it.
So, you can't, as you're going up on the FiO2, if you're going up on the PEEP to maintain oxygenation, you can't keep pouring fluid in because their injury to their lung is only going to get worse by giving them more crystalloid. Okay? So we've given them 4 liters of normal saline. The blood pressure, the mean arterial blood pressure is 60. What do we want? What mean arterial blood pressure do we shoot for in the ICU? 65, very good. Heart rate's 120, O2 sat's 95%, and this is now they're on 80% oxygen, right? Remember what I just told you? Now the FiO2 is going up to 80%, the O2 sat's 95%. Do I want to give more fluid? No. So what's the next intervention then? Pressor, very good. So it's the next intervention is not blood transfusion, not saline administration, but it's C. It's norepinephrine administration. All right. So the agents, you well know, the number one vasoactive vasopressor that we use in the ICU for septic shock is norepinephrine. All right. So you got dopamine, epinephrine, phenylephrine, sometimes a little phenylephrine, vasopressin, right, which is sometimes added, along with Levophed that we take care of patients who are in shock, dobutamine and milrinone. We don't use any milrinone anymore. I haven't used milrinone in years. And then you got the effects of these drugs. They either act primarily as a vasopressor or they can act as a vasopressor and an inotrope, as well. And again, the question I just asked you, which one's recommended in septic shock? Levophed, norepinephrine, or Levophed. Okay.
Before you go, how do we know we can give normal saline, and when do we stop normal saline and change it for the lactated rangers?
I mean, I think it depends. I mean, a lot of normal saline, lactated ringers. I mean, lactated ringers is a more physiologic solution in terms of resuscitation because of its balance of electrolytes that it has. More physiologic. Normal saline is good. The problem with giving too much normal saline is that sometimes, you end up creating a hyperchloremic, acidosis by the chloride that you give by giving lots of normal saline. So as long as somebody's kidneys are working, they're not having problems with potassium, lactated ringers, and they have a metabolic acidosis, I think lactated ringers is probably the preferred IV fluid to give. You can use normal saline. They're both crystalloids. They're both the same.
Yeah. No.
And I think that, I think that in a situation, if I have a patient who I see that, they're getting hyperchloremic, then I will say, as long as their kidneys are working, I'm not worried about the potassium. Though there's not a lot of potassium lactated ringers, I may say we should use lactated ringers, right? So
usually they give NS to neuro patients.
Right, because you want to keep the serum sodium high, those patients because of increased intracranial pressure.
Yeah.
Okay. What other interventions might be considered here in this patient? So really what they're getting at here, which is kind of what we've gone to now, which is what they're talking about here, other interventions, it's steroids. All right, so one of the things that you have to ask yourself, if you remember, we started talking about distributive shock. We talked about, well, there's other things within that category. There's septic shock, right? There's neurogenic shock. There's adrenal insufficiency.
Mm-hmm.
So there's a well-known, scenario. It's called CIRSE, which is critical illness related steroid insufficiency, right? Or sometimes patients' shock is just they're adrenal insufficient. They need steroids. So if I have a patient who I'm pouring volume in, whether it's normal saline, lactated ringers, and I got them on a vasopressor, and I'm adding vasopressin now because they're hemodynamically, they're just not behaving the way that I expect them to behave. Normally I ask myself the question, is there something else that's going on? A, do they have CIRSE, or B, do they have adrenal insufficiency? And then we give them steroids, right? Now what we're doing is, because of the data, this data that's come out about the use of what we call the COP protocol, but it's Merrick, a guy by the name of Merrick that did all this research. You give volume up to 4 liters, 5 liters, whatever, and then when patients are not behaving, then you go and you give them COP protocol, which is vitamin C, thiamine, and
So that's a new
steroids.
protocol now. Because when I saw my patient on bed 4, I said, why thiamine and then ascorbic acid is being given to this patient, and then steroid.
Right.
So,
And thiamine.
yes.
Right, so that's what they get, now. And what they found is that patients come off vasopressors much sooner, require not as much fluid, right? So it's kind of interesting. We've kind of come full circle with the use of steroids, because in my lifetime it was steroids and no steroids, and now we're back to the use of steroids in people in septic shock. So all the patients who have sepsis and septic shock, who get intubated, who are hypotensive, who are getting volume resuscitated and requiring a pressor, get this particular protocol. Okay.
How long do you give it for?
Either usually it's till they're off pressors, right? Till they're off pressors, or at least 4 to 5 days, right? 4 to 5 days. So how would fluid and vasoactive agents use different other types of shock? Well, hypovolemic shock, again, depending on what kind of shock it is, whether it's bleeding or not bleeding. If it's bleeding, you're going to give blood. If it's not bleeding, you're going to use crystalloid solution. Cardiogenic shock, maybe they get a little bit of fluid, maybe they get an inotrope, maybe they get a balloon pump. An obstructive shock, you got to relieve the obstructions, right? Tension pneumothorax, you need a chest tube. Pericardial tamponade, got to get fluid out around the pericardium, right? Pulmonary embolism, TPA, if there's a massive pulmonary embolism, saddle embolism, TPA, suction cap catheter, thoracotomy, something to relieve the obstruction. So norepinephrine stopped, normal saline solution has been reduced, blood pressure's up, mean arterial blood pressure is where we want it, urine output's only 25 cc's an hour, the creatinine's 2.5, and their BUN's 48, right?
Before you did, has this question. All this time we haven't spoken about the urine output of the patient.
So
how has urine output?
I don't know.
On this scenario, the patient.
It's going to kind of get to this, all right? So I don't know what the urine output's been. I can either tell you it's been adequate or it's been low. But here now you've got the patient where we've met endpoints of resuscitation, right? We have blood pressure, mean arterial blood pressure's up. The norepinephrine's been stopped. I'm going to assume his acidosis is better. His lactate's down, right? But now we got a different problem where the patient's urine output's only 25 cc's an hour. Maybe it was 25 cc's an hour before, but your creatinine's 2.5 and your BUN's 48, all right? Now, should we increase the fluid? Should fluid infusion be increased to improve urine output and renal function in this patient?
I don't
So what's the problem here? What's the patient got? Remember what we talked about end-organ perfusion, and if you don't have end-organ perfusion, how do we look at, end-organ perfusion, right? We look at lactate, base deficit, BUN, creatinine, LFTs. So people who get shock liver, their LFTs do what? Why is that? Because it's inadequate perfusion of the liver. BUN and creatinine go up. Why? Because inadequate perfusion. So this kidneys have taken a hit as a result of this profound hypotension that the patient had, which is the most common cause of acute tubular necrosis in the ICU, is hypotension. Then you see this, where the creatinine goes up, the BUN goes up. Does that mean you got to give the patient more fluid? The answer is no. No, the answer is no. You got to be careful, right? Just because the patient, you met endpoints resuscitation, just because the urine output has 25 cc's an hour, doesn't mean, and the kidneys are taking a hit, doesn't mean necessarily they need more volume. Because you have other information to say the patient's adequately volume resuscitated. Okay? Off pressors. I would assume no lactate. I would assume, a few things here, right?